The pediatric group would like to help Dr. Abrahamian celebrate his retirement from the military. Dr. Abrahamian has served with pride and a sense of humor for more than 20 years now. He has shared his experiences periodically with us, and I think it's really enriched our professional lives having a sense of his experience. So thank you for sharing that, Greg, and congratulations.
I want to thank the department for being patient during some of those periods, probably the more humorous deployments I've had in the past, so thank you.
Good morning, everybody, and thank you for coming. It's a pleasure to welcome Dr. Zaying Du here to look at our position of HLA Laboratory Director. Dr. Du got her medical degree in China, but did his compatibility and immunogenetics training at the University of Chicago between 2008 and 2010. Currently, she's the supervisor and the manager of the tissue typing laboratory at the University of Illinois at Chicago, and that's from 2011 and to the present. Her current duties, obviously, will include all of those parameters related to laboratory control, consultations, research, and really the overall scope of looking at the testing as well. She is ASHI qualified and certified as a histocompatibility director by the American Board of Histocompatibility and Immunogenetics, and that was in 2011. She's a very prolific writer with 22 published papers and approximately 30 abstracts, showing her the breadth of involvement and activity in the transplant area. Her talk today is going to be on solid phase anti-HLA antibody testing in kidney transplantation. Dr. Du.
Thanks, Dr. Reddick, for the nice introduction, and also thanks Dr. Reddick's invitation. It's my honor to be here today. I would like to share some of the knowledge and my research with you about the HLA antibody testing in kidney transplantation. In 1969, this famous publication by Dr. Tarsarki and his colleagues in New England Journal of Medicine demonstrates preformed cytotoxic antibody have detrimental effects on kidney transplantation. Since the significant clinical significant clinical association with the antibody. Later on, Dr. Tarsarki proposed a hormonal theory of the transplantation. It demonstrates the HLA antibody is a major cause for hyperacute rejection, early acute rejection, and chronic rejection. In one sentence, that is, the HLA antibody is a major cause for graft loss. Since the HLA antibody is important and the key factors in the transplantation, so HLA antibody testing, the technology becomes the crucial and the key consideration in transplant field. After 1969, the CDC Crossmatch, the technology involved from the flow cross-match, some kind of the solid phase testing for HLA antibody. And thanks for the Luminex technology developed, the technology can allow 100 of the different tests in one single tube, which suitable for the HLA polymorphism antigen systems. This technology uses polystyrene beads of the same size, which were internally labeled with 2 fluorescence dye in different ratios. These microbeads were pre-coded with some of your target analytes. For example, in our system, we targeted the analytes with the 100 different HLA antibodies, or HLA antigens. By incubating your patient serum with the pre-coded beads, after washing out the unused antibodies, the secondary antibody, which coated with the PE, then the antibody-antigen reactivity can be detected by the Luminex instrument through some specific software. Panel reactive antibody and the HLA antibody specificity can be identified by this assay. Here shows the example of the HLA specificity by Luminex. You can, since these beads coated with the specific HLA antigens, the serum of the specific antibodies can be easily identified through this technology. Here you can see the DQ5, DQ6, and some of the DR specific antibodies were identified. Also, the test provides the additional feature to detect the DQ alpha antibody as well as the DP alpha antibodies. First question we asked, can antibody tested by Luminex predict cross-match? At Gift Hope, which is our local organ procurement organization, we performed this study. We take 382 patients with PRA greater than 0. We performed the 1,112 cross-match against the 521 deceased donor. These patient serum HLA antibody were analyzed by lab screen single antigen beads. Antibody strains were represented using normalized beam fluorescence intensity. First, we investigate one single antigen, one single class 1 donor-specific antibody correlates with the T4 cross-match. From I'm sorry. Our cutoff is 20, which is at the 1 to 256 scale. For T4 cross-match, you can see around 100 to 2,000, 1,000 to 2,000 MFI can cause the positive T4 cross-match. Similarly, we see a little bit higher MFI required for B4 cross-match positivity. Since it's very common to see more than one DSA present in transplant patients, we investigate if the DSA have the addictive effects on T4 crossmatch and B4 crossmatch. This figure shows the clearly multi-DSA have addictive effects on T4 crossmatch. You can see here if the lower MFI for the one DSA do not cause the T positive crossmatch, but 4 or 5 of the weak DSA can cause positive crossmatch. This shows a different antigen, different antibody strengths. Because the stronger MFI shows the greater T4 crossmatch mean channel shift. This is true in the B4 crossmatch also. Then we investigate the DSA MFI correlates with the T4 crossmatch mean channel shift. This figure shows good correlation between class 1 DSA and the T4 crossmatch mean channel shift. Similarly, class 2 DSA shows a good correlation with the B4 crossmatch mean channel shift. So this study shows the DSA strengths we represent as a normalized MFI value here is significantly correlates with the 4 crossmatch strengths. Multiple DSA have addictive effects on the 4 crossmatch strengths. Based on the study, we categorize the DSA based on the MFI value. For example, the strong we define as a MFI greater than 5,000 will cause the 80% of the strong positive crossmatch and about 20% of the moderate positive crossmatch. For the moderate DSA, the MFI defines 2,000, 5,000. About 70% of them will have the moderate positive crossmatch. For the weak DSA, the MFI arranges the 700 to 2,000. About 50% of weak positive crossmatch. About 50% of the will come out the negative crossmatch. For the negative crossmatch, for the negative DSA, we define the MFI less than 700. About 90% will have the negative crossmatch results. So with this study, we performed the virtual crossmatch for potential recipient donors. Here's the example shows how we performed the virtual crossmatch. This patient have the strong DQ alpha 01 antibody and the DQ5, DQ6, and DR15, and so on antibody. And this patient also have the moderate DR1301 allele-specific antibody and the DR8, DR51. Compared to this potential donor, the donor have the DQ5, DQ6, DQ alpha 101. So this patient have the strong DSA against this donor. We predict we'll have the positive cross-match. For that case, the organ will not be provided to the donor, to the patient, I'm sorry. So here's show some of the experience in our medical center. This is our antibody testing algorithm for kidney and the kidney pancreas patient. For any new patient, we do the flow PRA screening for the antibody presence or not. If the PRA is greater than 0, we further do the Luminex single antigen to define the HLA antibody specificities. Then the patient will list on the illness. For the active patient, we do the Luminex PRA to screen the antibody presence a lot. If we do this screen every 3 months, so each patient will have 4 times antibody screen a year. If the patient is greater than PR greater than 0, we will test the Luminex single antigen beads annually. If the PRA change greater than 20%, Luminex single antigen will be performed. With this data, we will report unacceptable antigen on the illness. So we report the MFI greater than 2,000 as unacceptable antibodies. We put this data on the illness. And if the patient have the donor-specific antibody following the 3 scenarios, for example, have 1 strong DSA, have 2 moderate DSA, have 3 weak DSA. These patients will not get the real cross-match against the potential donors. So we test all the donors for A, B, C, DRB1, DQB1, DPB1, DQ alpha to exclude any potential donor-specific antibodies. In our medical center, so after implement the virtual cross-match, we see significant increase of the, we see significant increase transplant rate in 2009. And this transplant increase consistently since 2009. I only show data here is 2009, 2010. But the sensitized rate did not change since 2006, and so on. In Illinois, the one organ procurement organization gave the hope will take care of all the deceased donor transplantation for 10 centers. So we have the chance to do the multi-center analysis. So since in 2009, implemented the virtual cross-match, compared to 2006, the transplant increase dramatically. For the PRA greater than 80%, the increase 1.28 fold. For the PRA greater than 10%, the increase 1.9 fold. This increase consistent since 2009. So this practice of virtual cross-match significantly reduced the cold ischemia and the placement times, and also reduce the number of the patients cross-matches, and also save the time and the efforts and also cost. The practice of the virtual cross-match significantly increased the number of the transplant sensitized patients. Implement a virtual cross-match has resulted in significant increase, about 2-fold, of kidney transplants in sensitized patients since 2009. This increase has been consistent not only in a single center, but also in a multi-centers in a same donor service area. In our hospital, since last year, we also use virtual cross-match, perform the internal kidney paired donor exchange program. Besides, we participate in the nationwide KPD program. Since we have a lot of the sensitized patients, about the 40% of the patient is highly sensitized, we try to match the patient with different donor pairs. So, for example, this cartoon just shows the example here. For example, is donor one. Donor one has blood type A. Donor B, the recipient have the blood type B. They're incompatible, ABO incompatible. But the donor two have the blood type B, and the recipient have blood type A. So donor one can go to recipient two, but donor two can go to recipient one. Besides ABO incompatible, we do the HLA. We use this like the little program, do some of the internal HLA incompatible swap. Since last year, I think we have successfully performed about 5 HLA incompatible swap. These patients are doing well now. Also, this change can goes to 3 directions. This cartoon shows the blood type incompatible. This exactly same will apply to HLA incompatible swap. Since the Luminex testing is very sensitive, people were asked if the solid phase assay is too sensitive, unlike the flow cross-match and the CDC cross-match. Also, there's no conclusion if this pre-existing DSA by Luminex assay predicts outcome in kidney transplantation. In University of Chicago, we performed this study. With random retrospective study, we randomly select 201 kidney pancreas transplants patient from the 1998 to 2003. These patients were CDC cross-match negative, T4 cross-match negative, but the B4 cross-match was not set up the cutoff value because at that time they do not do prognosis treatment for the cross-match. We found 26 patients have the DSA, and among them, 16 patients have a class 1 DSA, and the 10 patients have a class 2 DSA. DSA negative patient have 175 patients. You can see from our data, the DSA patients have the worse outcome than the DSA negative patient. We further investigate what kind of HLA class type will affect the outcomes. We found the class 1 DSA greater than MFI greater than 1,000 will have the worst outcome than class 1 DSA negative and the class 1 DSA MFI less than 1,000. Unfortunately, we do not have enough sufficient biopsy data to further investigate the if the DSA will affect the pathological change. The similar results were reported by Dr. Pantel. He investigated the patients with the full cross-match negative, but 20 patients have the positive DSA, but 40 patients have the negative DSA. You can see in the very early beginning, DSA positive patients have the dramatic increase and antibody-mediated rejection. But later on, these trends were not so obvious. But in other group, also they investigate the patients from the negative full cross-match. They do not find any difference with the patient with the DSA positive or DSA negative regarding the acute rejection, as well as the 1 year and the 5 years graft survival. Dr. Amico investigates the patients only performed the CDC cross-match, no full cross-match performed. They found DSA patients have the higher probability to develop the acute rejection, as well as the antibody-mediated rejection. Also, DSA positive patients with antibody-mediated rejection have worse outcomes, survival. A large group study from France. In this study, they have the 400 patients and the 18 patients with the DSA. They found the MFI, the DSA patient with MFI 460, that is very low, will have the worst outcome. With the increase of the MFI of the DSA to 2,000, to 3,000 and greater, the graph outcome will be worse. Also, they reported not only the current serum DSA will predict the worst outcome. Actually, the historical peak serum with the DSA will predict better for the worst outcome. But similarly, but in contrast, another group also from Europe, this is from Germany, talk about the no association with the graph outcome with the DSA regarding the DSA class 1 or class 2, also the allele or the antigens. Whatever the MFI greater than 1,000 or greater than 3,000. So why is so much variability? We'll consider the different patient populations, probably induction and the maintenance in separation difference, and the differing histocompatibility lab techniques, and the variable MFI cutoffs, and also probably people not type the DP and the DQ, and for donor antigens cannot define the DP or DQ DSA. And different interpretation of the multiple allele beads. And the most important I'm considering is the antibody basal level when received the recipient. For example, some are performed for crossmatch, some not. Thanks for Dr. Mohan from the Columbia University. He reviewed majority of the publication, and he analyzed the data, talk about he divided this data in two groups. One is the DSA inactive CDC crossmatch. You can see from these slides the dramatic increase for antibody-mediated rejection in patients with the DSA detected by the Luminex. Also, you have the significant worse outcome for the graft survival. In DSA positive, even the CDC negative patient, CDC crossmatch negative patients. The second group they did is the DSA inactive for crossmatch patients. DSA detected by the Luminex can also predict the antibody-mediated rejection occurrence, also the worse graft outcome. So in some, we're considered based on the Luminex detected the DSA. We performed some risk assessment for the patient receive the graft or not. If the DSA is positive by solid phase, also have the crossmatch positive. The risk evaluation is a high risk, either goes to the cannot accept the graft, or the patient will need to go to the immune modulation. If the DSA is positive, strong positive, and have the crossmatch negative, we also assessment the risk factor is a moderate or high, will go to the same category. But if the DSA is negative, crossmatch negative, the risk factor will be low, will go through the transplant. If the DSA is negative, but come out some positive crossmatch, possible this is not because of the HLA specific reactivity, we evaluate the risk factor as a low. We'll suggest do the transplant. Okay, another thing performed in HLA lab importantly, recently, we are doing a lot of the HLA antibody testing for post-transplant monitoring. New Banff criteria for diagnosis antibody-mediated rejection, C4d is not necessary for diagnosis antibody-mediated rejection. But DSA still are there, so DSA becomes the golden standard to diagnosis of the antibody-mediated rejection. Banff criteria required that we need to document the DSA use the solid phase assays to reach the suitable sensitivity and the activity, sensitivity and the specificity. In University of Chicago, we perform some of the post-monitoring. We investigate the de novo HLA antibody, predict the associated with some pathological changes. We found basically the Class II DSA associated with the acute rejection and the chronic rejection. Represented here is the transplant glomerulopathy as a chronic rejection. But since at that time, the diagnosis based on the Banff 07. This is DSA is C4d is required to diagnose the antibody-mediated rejection. So part of the acute cellular rejection here should belong to the antibody-mediated rejection. So we see antibody of the Class DSA is significantly associated with the acute rejection and the chronic rejection. With this data, we further studied if the HLA DSA will predict of the pathological changes regarding the C4d deposition. Among all of these patients, we have the 40 antibody-mediated rejection cases from 59 patients with the HLA antibody testing at the time of biopsy. We define the DSA strains with as weak, the less than 2,000, moderate 2,000 to 4,000, strong the M5 greater than 4,000. We found the antibody-mediated rejection. Oh my gosh.
Let's go to this and find your slide. Was this it? Down there.
We have 39 patients with diffuse C4d deposition, and the focal we have 90 patients, and the negative have 5 patients with C4d deposition. We found the significant HLA antibodies associated with the antibody-mediated rejection. Particularly, here you can see Class II DSA have significant associated with the antibody-mediated rejection specimens. And further, we found the Class II DSA associated with the diffuse C4d deposition. Also, as a class, Class 1 and Class 2 associated with the diffuse C4d deposition. Also, Class 2 is significantly higher in focal C4d deposition. And further, we see the data. There's a low regarding the antibody strengths. There's a low significance associated with the Class 1 DSA in all of the C4d deposition groups. But we do see like the strong Class 2 DSA associated with C4d deposition. We further ask if DQ or DQ antibody contributed to the C4d deposition. This figure shows both DQ or DR antibodies play the same role. There's no difference on the C4d deposition difference. Statistics analysis shows the Class 2 DSA have significant difference in C4d deposition. In the diffuse C4d group, we see the 5,000 of the DSA in the focal C4d deposition group, we see around 1,500 of the C4d DSA. In the negative group, there's DSA is kind of low. In this study, in summary, in kidney transplant patients, HLA Class II DSA detected at the time of biopsy significantly correlates with antibody-mediated rejection. Strong HLA Class II DSA greater than MFI greater than 4,000 significantly correlates with the diffuse C4d deposition, in particular capillaries. In contrast, strains of HLA Class I DSA does not correlate with C4d deposition. Both DR and DQ DSA are significantly associated with C4d deposition. These results underline the value of Class II DSA strains as an important marker in the diagnosis of antibody-mediated rejection. Another important job we're doing in the laboratory is monitoring desensitization. Sensitization from the previous transplant, pregnancy, transfusion will cause the significant barrier for receiver transplants. The data in illness on the waiting list increase, but the patient with highly greater than 20% of the PRA receive the transplant, the chance is very, very low. To help them, to help these patients receive grafts, a lot of hospitals perform the immune moderating to remove the HLA antibodies and let the recipient to accommodate the grafts. I only show two cases here to indicate how we do the HLA antibody monitoring to add the add the decision for patient for patient to receive a transplant. This patient is a 40 years old African American female with end-stage renal disease secondary to SLE and diffuse membrane glomerulonephrititis. The patient have 1 pregnancy and 4 blood transfusions. She's on hemodialysis. Her potential donor is her niece. Pre-transplant evaluation, the patient have the DSA against the donor, class 1 is A25 and B44, and the class DR11, DR52. CDC cross-match is negative. Full cross-match is T positive and the B positive. So the patient received the desensitization moderating in the hospital. They have the capable plasmapheresis, rituximab, and with the SIMO and induction the IVIG treatment. In the lab, we do the DSA monitoring. You can see the pink line is the creatinine. This is blue dot is the pink line is the creatinine. The red dot is class 1 DSA MFI. Astrocytes, the red is the class 2 DSA. You can see the DSA MFI around 5,000-6,000. With moderating, the DSA decrease to under 2,000 here. So the patient received the transplants here. Then about post-transplant 1 month, the patient have the biopsy, shows a negative finding, and also there's no DSA were detected in the patient. The patient has been doing very well, even she presents the class 1 and the class 2 DSA. Another case is a 78 African-American female with end-stage renal disease secondary to hypertension. She had 8 pregnancies and multiple transfusions. Also, she was on hemodialysis. Her potential donor is her son. Pre-transplant evaluation, this patient have the class 1 to class 2 antibody, but only class 2 DSA, DR18, DR52 are present. CDC crossmatch is negative, and the T4 crossmatch is negative. B4 crossmatch is positive. But in contrast to the previous case, these patients have very high MFI for the DSA, around the, above the 15,000. In the lab, we monitor the DSA MFI during the immune separation and the immune moderating process. When the DSA was dropped to 2,000, the patient received the kidney from her son. But just 20 days later, when we tested the DSA jumped back to the pre-transplant level to 15 or 16,000. And 3 months later, the DSA still kept in the high level, and the patient have the biopsy, have no significant finding, but and 20 days later, since biopsy, the patient have symptoms, have the edema, urinalysis, and when we test the DSA jumped to 8,000, 10,000 at that level. But the biopsy shows the patient have the transplant glomerulopathy. So before the significant biopsy finding, DSA ahead of the biopsy finding to predict the worst outcome of the patient. So compare these two cases. The first case have the moderate or lower DSA. For this second case, their DSA have very high MFI value. The second is the DSA data, significant data is prior to biopsy data. So this will help the clinician to manage or treat the patient properly. So in conclusion, solid phase anti-HLA testing identifies a comprehensive HLA class 1 and class 2 antibody profiles. DSA tested by Luminex platform successfully predicts positive cross matches, which adds the donor selection and allocation. DSA monitoring by Luminex platform facilitates proper management of highly sensitized patients to overcome the transplant barrier. Post-monitoring of DSA adds the antibody-mediated rejection diagnosis and the treatment of the rejection. I would acknowledge all my mentors or colleagues when I was in this different institution. I particularly thanks Dr. Susana Marino and Dr. Andres Jaramillo, who trained me in the clinical immunogenics. Also thanks Dr. Sujata Gaitandi. She's my part-time director at the UIC. She's a hemopathologist, and she supported me to run the HLA lab very well. So, and also at the UCLA Immunogenic Center, Dr. Yin Reid and Dr. Roger Ningen brought me to this field. And also under their supervision, I do some of the research regarding the immunogenetics and also the transplant biomarkers development. I think I benefit from all of the training and all of supervision. So I will stop here, and I would like to take any question regarding my talk. Thank you very much.
I was curious, your last two slides are close by, on your desensitization of the 78-year-old, when you saw that rebound in the DSA, you don't show it on your slide, but I assume the program must have instituted plasmapheresis or something to drop the antibody levels back down?
Yes.
Day 26?
Yes, this is, yes, here they do the planned the desensitization protocol based on this, but when they saw they have rebound the DSA back to 2000s MFI, they do plasmapheresis and the IVIG, the patient cannot tolerate the further plasmapheresis and IVIG. They have she had a significant side effects of the, so that's why, that's one of the reasons too. Okay.
I was just curious if your DSA monitoring post-transplant is done surveillance routinely or only by clinical symptoms?
Clinical symptoms.
And do you happen to know if you have difficulty in reimbursement for that?
Because where the state hospital, also the physician, ask a lot of the DSA test. So we do like this. We make agreement around for DSA, we test the 2 weeks apart, minimal. So we cannot do, because physician wants to do the 3 days apart, 3 days apart. They have, when they have the plasmapheresis, they will do the DSA test. These tests are very expensive. The reagent itself, the per well is $100, so only reagent. So it's so we just make some agreement to adjust maybe after treatment, maybe give it some time to let the DSA represent the real status, so we will perform that test.
That was a very complete talk, thank you. When you have a negative DSA and a positive crossmatch, what do you attribute the positive crossmatch to?
Possible is something is non-HLA related, besides of the HLA, because the crossmatch cell-based assay, the cell surface is junk. Every molecules will have the potential react with the serum, some antibody against. For that case, then normally we will further do tests. For example, do auto crossmatch to eliminate any auto antibody, or we treat the serum with the IgM to remove some IgM. To treat the DTT, remove the IgM antibody. We further, or either we absorb the serum with the patient cells to remove. We will further test for that case. Normally we do that. In the lab we don't, but for some particular case we have so we will send out for MICA or some of the phospholipid antibodies.
Are there certain criteria that you follow when you're making the decision between pursuing paired exchange versus desensitization? Is there a certain combination that you're looking for at your program?
No, normally the physician will willing to do some of the DSA test. I'm sorry. So actually, so you ask the desensitizing protocol, right?
I was just curious if you defaulted and first pursued desensitization, or if you first pursued a paired exchange in a certain HLA crossmatch situation.
The pair exchanges we perform internally, so we just if we have the patient that consent for that they're willing to exchange, we put it in the program. The program from the Johns Hopkins is a small program. We put it there. So we will maintain the database every week. So they will send out the report to the physician. They will decide which pair we need to, proceed or something like that. Yeah, but also the database is small also internally, so it's hard to very hard to find the donor for the highly sensitized patient. For that case, they will go through to the desensitization protocol.
Other questions? Great. Thank you, Dr.
Thank you.